Today we'll hear about positive news for pancreatic cancer patients, Phase 2 results in ovarian cancer, and a next-generation EGFR inhibitor for lung cancer. Welcome to OncLive News Network. I'm Lauren Ettlinger.
I'm Justin Gallagher. New therapy is on the horizon for patients with pancreatic cancer as the FDA has granted fast-track designation to MM398, an agent that combines liposomal irinotecan plus 5-FU and leucovorin as a second-line treatment of advanced disease. The FDA designation was based on data from the Phase 3 NAPOLI-1 study that were presented at the 2014 World Congress on Gastrointestinal Cancer in June of 2014. In that study, which enrolled 417 patients, treatment with MM398 plus 5-FU and leucovorin extended overall survival by 37% and progression-free survival by 44% when compared with 5-FU and leucovorin alone, following progression on a gemcitabine-based regimen. Notably, MM398 monotherapy did not demonstrate superior efficacy compared with 5-FU and leucovorin. 61% of patients in the study had cancer in the head of the pancreas and 68% had liver metastases. Merck Pharmaceuticals announced that it plans to initiate the new drug application submission process in 2014, with the targeted completion date set for the beginning of 2015. Patients who have metastatic pancreatic cancer that is refractory to gemcitabine-based therapy are in desperate need of better treatment options. Currently, there is no standard in this setting.
Next, the PARP inhibitor rucaparib appears to be safe and effective as a treatment for patients with BRCA-mutated ovarian cancer. In an interim analysis of the ARIEL-2 Phase 2 study presented by Dr. Elizabeth Swisher from the University of Washington School of Medicine, the overall response rate for rucaparib in BRCA-positive women was 70%. A novel companion diagnostic test was used to identify patients who are likely to respond to rucaparib based on BRCA1 and 2 mutations and BRCAness gene signature in tumor tissue samples. In patients who are identified as positive by this test, the response rate was 40% versus only 8% in those without the signature.
In breast cancer news, an updated joint analysis of 2 large Phase 3 randomized studies confirmed that the addition of 1 year of adjuvant trastuzumab to chemotherapy continues to demonstrate statistically significant long-term improvement in overall survival and disease-free survival for patients with early-stage HER2-positive breast cancer. Recently published in the Journal of Clinical Oncology, this analysis performed after 8.4 years of follow-up showed that patients who received adjuvant trastuzumab in addition to chemotherapy had an overall survival that was 37% greater than those receiving chemotherapy alone. The 10-year overall survival rate was 84% with trastuzumab, compared with 75.2% for chemotherapy alone. Similarly, the study found a 40% improvement in disease-free survival with a 10-year disease-free survival rate of 73.7% in the trastuzumab arm compared with 62.2% in the chemotherapy-only arm. Dr. Harold Burstein, an associate professor of medicine at Harvard Medical School, explained, "First and foremost, we learned that the benefits of trastuzumab are robust and durable. These proportional risk reductions translated into meaningful differences for all identified clinical subsets of HER2-positive breast cancers. The study showed only a minor increase in the cardiac-related dysfunction, a known risk associated with trastuzumab. Overall, the study confirmed that the long-term benefits of trastuzumab continue to far outweigh the risk."
In lung cancer news, ruxolitinib demonstrated promising clinical activity in a Phase 1-2 study evaluating patients with EGFR T790M mutant non-small cell lung cancer. The third-generation irreversible tyrosine kinase inhibitor selectively targets mutant forms of EGFR while sparing wild-type EGFR. Ruxolitinib was associated with an objective response rate of 67% in heavily pretreated T790M positive patients who were treated with either 625 milligrams or 500 milligrams dosages. The median progression-free survival was 10.4 months. In EGFR positive but T790M negative patients, ruxolitinib continued to demonstrate responses. For these patients, the objective response rate was 36% and the median progression-free survival was 7.5 months. Most treatment-related adverse events were grade 1 or 2. Because ruxolitinib spares wild-type EGFR, skin rash is far less common than seen with other EGFR inhibitors. The most common treatment-related adverse events reported were hyperglycemia, diarrhea, nausea, and reduced appetite. Based on earlier data, the drug received a breakthrough designation from the FDA. The manufacturer, Clovis Oncology, expects to submit findings from the study to the FDA by mid-2015.
On November 18th, the FDA granted Juno Therapeutics chimeric antigen receptor T-cell, or CAR-T agent, JCAR 015, an orphan drug designation for acute lymphoblastic leukemia. This decision was based on early phase 1 trial results showing that 88% of patients with precursor B-cell ALL experienced a complete response. CAR T-cell therapies are a form of adoptive cell therapy in which the patient's T-cells are cultured and then primed to specifically recognize target tumor cells prior to reinfusion into the patient. The drug is also being investigated in a phase 1 clinical trial in patients with relapsed or refractory aggressive B-cell non-Hodgkin lymphoma. JCAR 015 is only one of Juno's 3 chimeric antigen receptor T-cell or CAR T-cell agents in development. All 3 agents target the CD19 antigen. JCAR 017 will be investigated for use with pediatric and young adult patients with relapse or refractory CD19 positive leukemia. JCAR 014 will be tested in patients with CD19 positive CLL, ALL, and NHL. CAR T-cell therapies also are being developed by Novartis and Kite Pharma. A published analysis of phase 1 and 2 data on Kite's CAR T-cell agent KTE-C19 showed a complete response rate of 61.5% and partial response rate of 30.8% in patients' advanced B-cell malignancies.
Pfizer and Merck Darmstadt have agreed to collaborate on the development of a PD-L1 inhibitor as a potential treatment for multiple types of cancer. Under the agreement, Merck Darmstadt will receive an upfront payment of $850 million and is eligible to receive regulatory and commercial milestone payments up to approximately $2 billion. Both companies will jointly fund all development and commercialization costs. Separate from the PD-L1 programs, Pfizer and Merck Darmstadt will also work together to develop Pfizer's anti-PD-1 antibody in phase 1 trials. There are currently 2 clinical development programs underway evaluating Merck Darmstadt's anti-PD-L1 antibody. In September 2014, interim data were presented from an ongoing phase 1 study demonstrating a complete response and partial responses in patients with non-small cell lung cancer and ovarian cancer. Additional data are expected in 2015. And that's all the oncology news for this week. I'm Lauren Ettlinger.
And I'm Justin Gallagher. Thanks for watching OncLive News Network. We'll see you next time.